Hi guys. So today in our series of lectures on renal system in pediatrics, we are going to talk about nephrotic syndrome. This is very common case in pediatrics. Plus you guys must have seen cases of nephrotic syndromes in pedia ward. Okay, this is very important topic in case of your final year exams as well, be it your theoretical exams, practical exams, right? और competition में तो है ही, okay? काफ़ी easy case होता है final year viva के according, तो काफ़ी ज़्यादा struggle होता है अलॉटमेंट में कि किसी को नेफ्रोटिक सिंड्रोम का केस मिल जाए, राइट? पासिंग रेट ज़्यादा होता है, इवन एप्लीकेबल फॉर पीजी स्टूडेंट्स. ओके, so let's talk about nephrotic syndrome. Nephrotic syndrome is basically problem in which kidneys have a single problem of losing lot of albumin in urine, lot of protein in urine. So this is case of massive or nephrotic range proteinuria, right? And mostly this is selective, so this is due to loss of albumin mainly. So this is massive albuminuria, resulting into decreased albumin in blood, okay, less than 3 gram per deciliter, resulting into decreased oncotic pressure, right, and further resulting into swelling all over the body. But this swelling typically first appears over face, and that to our periorbital area known as periorbital edema. Okay. Isolated problem of spilling lot of proteins in urine. So massive proteinuria of nephrotic range is equivalent to nephrotic syndrome. तो अगर मान लो आपके पास कोई पेशेंट आता है वेल लुकिंग बेबी with isolated complaint of swelling all over the body, starting first around eyes in form of periorbital edema, always think of nephrotic syndrome if patient presents mainly in age group of 2 to 8 years. Okay, there are many causes of nephrotic syndrome which we will discuss over a period of time. Okay, well looking baby. So let's talk about few cardinal features of nephrotic syndrome. This is group of disease characterized by, इसका मतलब बहुत सारी diseases हैं जो nephrotic syndrome जैसे present करेंगी. Most common of them is minimal change disease in pediatrics, okay, idiopathic condition, and this shows very good response with steroids. So drug of choice will be steroid, particularly prednisolone. Cardinal points में देखते हैं. First one is massive proteinuria in the range of greater than 3.5 gram per day. This absolute value of protein loss per day can be estimated by 24-hour urinary protein estimation. Okay, but in pediatrics, early estimation is more important. So in pediatrics, if proteinuria is in range of more than 40 milligram per meter square per hour, this is termed as massive proteinuria or nephrotic range proteinuria, right? Enough to be labeled as a case of nephrotic syndrome. Then lot of proteins has been lost in urine, so blood albumin levels will decrease. So serum albumin levels less than 3 gram per deciliter is known as hypoalbuminemia. Once albumin levels go down below critical level, then patient's oncotic pressure will decrease. Decreased oncotic pressure will result into edema. And typically, edema starts first around eyes, okay, that is known as periorbital edema. Then there are few other things also in case of nephrotic syndrome, right? There will be compensatory increase in synthesis of proteins and lipids from liver. So this will also increase lipoprotein synthesis. And due to this, lipid levels also increase, right? Particularly, this enhances cholesterol levels. Okay, cholesterol ज़्यादा होगा. It is case of hyperlipidemia. If there is more of cholesterol, if there are more of lipids in your blood, even lipids can be excreted out along concentration gradient in kidneys, resulting into lipiduria. Earlier, hyperlipidemia used to be a criteria of diagnosing nephrotic syndrome, but as of now, this has been eliminated. Okay. Then you have hypercoagulability. Why hypercoagulability in case of nephrotic syndrome? First, due to loss of antithrombin 3 in urine. Antithrombin 3 in urine एंड सेकेंड ड्यू टू इंक्रीज फाइब्रिनोजन सिंथेसिस फ्रॉम लिवर. ये भी एक प्रोटीन है, इंक्रीज्ड फाइब्रिनोजन synthesis by liver. So nephrotic syndrome is a hypercoagulable state. भले ही यहाँ पे edema होगा, usually giving Lasix is avoided. Lasix means furosemide. अगर furosemide देते हो simply to resolve edema, it can result into constriction of intravascular volume. Blood और viscous होगा, clotting factors की density और increase हो जाएगी, and this can worsen the condition by what? Increased thrombosis. ये कुछ कार्डिनल फीचर्स थे. हम लोगों ने क्या डिस्कस किया? देयर विल बी मैसिव प्रोटीनूरिया मोर देन 3.5 ग्राम पर डे लीडिंग इनटू hypoproteinemia, that is serum albumin going down below 3 gram per deciliter, and then resulting into edema due to decreased oncotic pressure. Plus there is compensatory increased synthesis of proteins by liver, which in turn also synthesizes lipoproteins, increasing the lipid level, that is hyperlipidemia, and this can also lead to lipiduria. तो चीज़ें कितनी सिंपल हैं, right? First thing which has to be remembered is massive proteinuria, resulting into what? Hypoalbuminemia, resulting into third, what is that? Gross edema. Then we have discussed few additional things also, be it hyperlipidemia, cholesterol levels more than 200, serum cholesterol means more than 200 milligram per deciliter, then lipiduria and hypercoagulability, right? So things are very, very simple. These are the cardinal features of nephrotic syndrome, okay? Clinically क्या मिलेगा? Well looking baby, most often presenting to you in age group of 2 to 8 years, presenting to you with chief complaints of swelling all over the body, starting from eyes, that is periorbital edema. कुछ details और देख लेते हैं. We are talking about nephrotic syndrome. Most common cause क्या है? Idiopathic. और idiopathic में भी most common cause क्या है? That is minimal change disease. So you have two types. One is idiopathic or primary, and most common cause is minimal change disease. But sometimes nephrotic syndrome can be due to other causes also in idiopathic category, that is known as nephrotic syndrome with significant lesions. जैसे membranoproliferative हो सकता है, membranous glomerulonephritis हो सकता है, focal segmental glomerulosclerosis हो सकता है. ये सारे जो सिग्निफिकेंट लीजन के डिसीजेज हैं, मोस्टली दे प्रेजेंट एज नेफ्रेटिक सिंड्रोम. ओके, तो कैसे डिफ्रेंशिएट करोगे इन सारे डिसीजेज से? हम लोग जो नेफ्रोटिक सिंड्रोम और नेफ्रेटिक सिंड्रोम के बीच में डिफरेंसेस होते हैं उनको एनुमरेट कर सकते हैं. मिनिमल चेंज डिसीज रेस्पॉन्ड्स वेरी वेल टू स्टेरॉइड्स, बट दीज सिग्निफिकेंट लीजन्स डू नॉट रेस्पॉन्ड वेल टू स्टेरॉइड्स, बट फर्स्ट ट्रायल ऑफ स्टेरॉइड्स हैज़ टू बी गिवन. Minimal change disease में there is loss of lot of lipids in urine also, so this is known as lipoid nephrosis as well. Okay, यहाँ पे लिपिड के कास्ट वगैरह भी मिल सकते हैं यूरिन में. Most common cause is minimal change disease, right? And edema and selective proteinuria are features of nephrotic syndrome. We have already discussed this. और ऐसे पेशेंट में कुछ कॉम्प्लीमेंट प्रोटीन्स का भी लॉस होता है, इसलिए चांसेस ऑफ इन्फेक्शन आर वेरी हाई. And over to it, you will also give steroids. Right, whenever you diagnose this condition, that can also lead to increased chances of infections. इसीलिए nephrotic syndrome में you have to add few vaccines, additional vaccines we'll discuss. Okay, and then you have investigation part. Major investigation will be related to urine examination, right, to demonstrate the protein loss or albumin loss in urine. But other things can be light microscopy, electron microscopy and immunofluorescence test. Okay, light microscopy कब normal होगी? Minimal change disease में. Okay, so you have normal or no abnormality in light microscopy. Whereas electron microscopy, if in case of minimal change disease is done, right after biopsy, it can demonstrate effacement of food process of podocytes. C3 will be normal, unlike glomerulonephritis, particularly post-streptococcal glomerulonephritis, and immunofluorescence will show no deposits at all. तो नाम ही मिनिमल चेंज डिसीज है, लाइट माइक्रोस्कोपी में कुछ नहीं मिलना है. इलेक्ट्रॉन माइक्रोस्कोपी में थोड़ी बहुत फाइंडिंग मिलेगी, वी विल डिस्कस. ट्रीटमेंट विल बी मेनली बाय स्टेरॉइड्स. देखते हैं. So you have many features of nephrotic syndrome. Mainly it is primary or idiopathic, और secondary nephrotic syndrome हो सकता है, that is due to some other diseases, pre-existing diseases. जैसे मान लो किसी को हेपेटाइटिस बी है, ऑटो इम्यून डिसीजेस के साथ एसोसिएटेड हो सकता है, ऑटो इम्यून डिसीजेस एसेट्रा. Not worth discussing, but you should know the secondary causes of nephrotic syndrome as well. Idiopathic means you have most common as a what? Minimal change disease. And then you have few nephrotic syndrome, idiopathic with significant lesions. Nephrotic syndrome with significant lesions. क्या क्या आ जाएंगे यहाँ पे? Focal segmental glomerulosclerosis. Then you have membranous glomerulonephritis. What else? You have mesengoproliferative glomerulonephritis. Proliferative glomerulonephritis. So these are nephrotic syndrome with significant lesions. This responds well to steroids and they might not respond well to steroids. Okay? So basically you have primary, that is idiopathic, then you have secondary, and in primary you have mainly what? Minimal change disease, and then you have nephrotic syndrome with significant lesions. Those include focal segmental, membranoproliferative, and mesengoproliferative. These with significant lesions might not respond well to steroids, और हो सकता है इनमें कुछ features of nephritic syndrome हो. Therefore you need to be very clear what is nephrotic syndrome, what is nephritic syndrome. So these are the primary or idiopathic causes of nephrotic syndrome. सबसे ऊपर यहाँ पे minimal change disease है. Then you have what? Nephrotic syndrome with significant lesions. Then you have secondary causes of nephrotic syndrome in which you have to treat the primary cause. जैसे आपका HIV, hepatitis B, malaria, autoimmune diseases, even drugs. Okay. Once you need to also understand the differences between nephrotic and nephritic syndrome. Nephrotic syndrome, as we have already discussed, nephrotic syndrome is simply increased loss of proteins in urine, proteinuria, massive proteinuria, nephrotic range proteinuria greater than 3.5 gram per day. Nephritic syndrome में इससे कम होगा, almost 2 gram per day तक होगा. Okay, so there is massive proteinuria, there is mild proteinuria. यहाँ पे आपका क्या होगा? एल्ब्यूमिन काफ़ी कम हो जाएगा. देयर विल बी ग्रॉस एडिमा एंड देयर कैन बी मिनिमल एडिमा. व्हाट एल्स? देयर कैन बी हाइपरटेंशन. देयर इज हाइपरटेंशन इन केस ऑफ नेफ्रेटिक सिंड्रोम. देयर इज हेमेच्यूरिया in case of nephritic syndrome resulting into cola colored urine, and there is also oliguria in case of nephritic syndrome, whereas these manifestations are usually absent in case of nephrotic syndrome. Nephritic syndrome के क्या क्या causes होंगे? You can start with post-streptococcal glomerulonephritis and also those causes which are causing nephrotic syndrome with significant lesions. It means that nephrotic syndrome with significant lesions can present either way, either in form of nephrotic syndrome or in form of nephritic syndrome. Discuss करेंगे one by one each of them. Right, let's talk about congenital nephrotic syndrome. If nephrotic syndrome presents within first 3 months of life, right? So it is mostly hereditary. It is mostly due to few gene defects, right? So you have two genes, NPHS1, representing nephrin. Okay, this is most common hereditary nephrotic syndrome, that is congenital nephrotic syndrome, known as Finis type. Right? Then you have one more gene, that is NPHS2, which encodes for podosine, and this mainly causes steroid-resistant nephrotic syndrome. Steroid-resistant nephrotic syndrome. Right, so this is nephrin. Okay, so there are two gene mutations which can lead to congenital nephrotic syndrome. One is NPHS1 and the other one is NPHS2. Okay, Moving ahead, what about the pathogenesis? Why we are getting isolated loss of lot of proteins in urine and other things is staying normal? बाकी सारे complications secondary to massive proteinuria है. So pathogenesis of nephrotic syndrome lies in the fact of massive or nephrotic range proteinuria. ओके, मैसिव और नेफ्रोटिक रेंज प्रोटीनूरिया. अभी हम लोगों ने क्वांटिफाई भी इसको किया था. वी टॉक्ड अबाउट ग्रेटर देन 3.5 ग्राम पर डे और ग्रेटर देन 40 मिलीग्राम पर मीटर स्क्वायर पर आवर. ओके, आगे चल के यूरिन डिस्ट्रिक्ट भी करेंगे ग्रेटर देन 3+ और 4+. ओके, यूरिन डिस्ट्रिक्ट टेस्ट स्पॉट टेस्ट होता है, बेड साइड टेस्ट होता है, सैंपल को लैब नहीं भेजना पड़ेगा. ओके, so you have two things in pathogenesis. One is effacement of food process of podocytes. Food process of podocytes. And what about second thing? That is loss of polarity. अभी डिस्कस करेंगे किसके किसके बीच में पोलैरिटी लॉस होगा. These are food processes. अगर ये efface हो जाएं, right, something like this, it can lead to passage of albumin in urine, that is albuminuria. Okay, effacement can increase the size of filtration slits, which can lead to passage of albumin in the filtrate in larger quantities. Okay, that is albuminuria. यहाँ पे हम लोग क्या देख पा रहे हैं? There is problem with the food process of what? Epithelial cells known as podocytes. So these are the various food processes of podocytes. These can get effaced. Okay, so first is effacement of food processes of podocytes. Okay, food processes of podocytes. What about second thing? That is loss of polarity. कैसे polarity की बात हो रही है? Loss of polarity. See, these albumin particles are negatively charged. Okay, and the filtration membrane, that is glomerular basement membrane, is also negatively charged. Right, this is albumin and this is glomerular basement membrane or the filtration membrane. So negative charges repel. But in case of nephrotic syndrome, albumin remains negative, but this glomerular filtration membrane, right, becomes positive. So the polarity is getting lost, resulting into more filtration of albumin across the filtration membrane, right? Negative, positive charges attract. Okay, so earlier it was both were negative. Albumin was also negative and the filtration membrane was also negative. But in case of nephrotic syndrome, filtration membrane became positive. Albumin is negative, mostly negatively charged protein. So it will be filtered more via filtration membrane. Okay. And regarding diagnosis of nephrotic syndrome, you have urine examination. Okay, so you can quantify the loss of urine, the loss of proteins in urine. So you can go for 24-hour urinary protein estimation. हम लोगों ने डिस्कस किया था more than 3.5 gram per day, or if you can estimate R-wise, it is more than 40 milligram per meter square per hour. Okay, so this is nephrotic range proteinuria. Anything less than this will not be considered nephrotic range proteinuria. इसका मतलब alternate diagnosis हम लोगों को सोचनी होगी, be it nephritic syndrome, chronic kidney disease or any other condition. Then you have a spot test in form of UP-UC ratio, urine protein versus urine creatinine, right, known as UP-UC ratio. If this is more than 2, it indicates nephrotic syndrome. Then you have urine dipstick test. Dipstick से हम लोग देख सकते हैं 1+ loss of protein है, 2+ है, 3+ है, 4+ है. अगर 3+ और 4+ होगा, this signifies higher degree of protein loss in the range of 3.5 gram per day or more than 40 milligram per meter square per hour. So this will also support the diagnosis of nephrotic syndrome. ये स्पॉट टेस्ट है एंड यूरिन डिस्ट्रिक्ट टेस्ट इज बेड साइड टेस्ट. ओके, पेरेंट्स को भी बोल दिया जाता है यूरिन डिस्ट्रिक्ट से मॉनिटर करते रहें कि बच्चे में प्रोटीनूरिया हो रहा है कि नहीं हो रहा है. सो यूरिन एनालिसिस इज द इन्वेस्टिगेशन ऑफ चॉइस. पहले कोलेस्ट्रॉल का भी लेवल होता था क्राइटेरिया में, बट नाउ डेज कोलेस्ट्रॉल लेवल कैन बी डन इन नेफ्रोटिक सिंड्रोम, इट विल बी हायर मोस्ट ऑफ्टन, but it is not in diagnostic criteria. So you have urine dipstick test for the loss of proteins in urine, और ज़्यादातर हम लोगों को ये 4 रीडिंग मिलती है. हम लोग इसको कलर बॉक्स से कंपेयर कर लेते हैं. 1+ means proteinuria in the range of 30 mg per deciliter, 2+ is 100 mg per deciliter, 3+ is 300 mg per deciliter, and 4+ is 1000 mg per deciliter. 3+ and 4+ represent the nephrotic range. Okay, nephrotic range proteinuria. कैसे याद करोगे? 3+ 300, 4+ 1000 से ज़्यादा, something like this. 1+ 30, 1+ 30, 3+ 300, something like this. Right? देखते हैं 1+ equivalent to 30 mg per deciliter loss of protein in urine, 2+ 100, 3+ 300, 4+ greater than 1000 mg per deciliter. ओके, हम लोगों ने क्या कहा? 3++ याद करना है. 3+ greater than 300 mg per deciliter, 4+ becomes greater than 1000. ओके, अगर 1+ 2+ ऐड करना चाहो तो 1+ 30, 2+ 100. तो दिस इज वेरी सिंपल. स्पॉट टेस्ट है, बेड साइड टेस्ट है, पेरेंट्स को भी बता सकते हो, तो वो भी कर सकते हैं इस टेस्ट को. ओके, कैसे रेमिशन में जाएगा? हम लोग कहेंगे रेमिशन का मतलब पेशेंट हैज़ रिकवर्ड अगर 3 consecutive डे क्या हो जाए? नीलायन. ओके, यूरिन आरएन भी नीलायन. वैसे आरएन हम लोग कराते नहीं यहाँ पे रोज डेली बेसिस पे. डिप्स्टिक टेस्ट इफ कम्स आउट टू बी नेगेटिव फॉर 3 consecutive days, दिस इज नोन एज remission in case of nephrotic syndrome. But unfortunately, even after getting full treatment, patients of nephrotic syndrome can go into relapse. अभी हम लोग देखेंगे what are frequent relapsers and what are infrequent relapsers. तो मेरे ख्याल से डायग्नोस्टिक पार्ट क्लियर है. कोलेस्ट्रॉल लेवल भी करा सकते हो, KFT भी करा सकते हो. कोलेस्ट्रॉल हाई आएगा, KFT नॉर्मल आएगा. ओके, अगर एसाइटिस है, यू कैन क्वान्टिफाई इट बाई अल्ट्रासाउंड ऑल्सो. बट हियर एसाइटिस what is part of the disease. Unless there is tenderness of abdomen, you don't need to go for ascitic tap. Okay, ascitic tap नहीं करना है. So let's talk about treatment. Treatment की बात अगर हम लोग करें, drug of choice is steroid, that is prednisolone, and this is mainly for minimal change disease. अगर significant lesions होंगे तो शायद respond ना करें. But you have to start with steroids only. Okay, in case there is steroid resistance, then you can add other cytotoxic drugs or other immunosuppressants. Let's say what is the treatment. There is 12-week course. 12-week course में क्या है? First 6 weeks and then next 6 weeks, 6 weeks, then again 6 weeks. पहले 6 week में at the rate 2 mg and next 6 week में at the rate 1.5 mg per kg per day हम लोगों को क्या देना है? स्टीरॉइड्स देने हैं. At the rate 2 mg per kg per day, at the rate 1.5 mg per kg per day, but this has to be given on alternate days and this has to be given daily. Okay, this is the treatment. तो 6 वीक हम लोगों को देना है. मान लो पेशेंट ऑल्टरनेट डोज पे है और रिलैप्स होकर दिया, या मान लो पेशेंट ने रिलैप्स हो गया, देन यू कैन रीस्टार्ट दिस डोज. और जब रेमिशन में चला जाए तो यू कैन अगेन स्टार्ट alternate doses of prednisolone at the rate 1.5, but duration will be lesser, approximately 4 weeks. तो अगर ट्रीटमेंट की बात किया जाए, you have to remember 6 week plus 6 week. यहाँ at the rate 2 mg per kg per day, at the rate 1.5 alternate day, and here daily. एक स्मार्ट स्टेटमेंट है, इतना तो एटलीस्ट आना चाहिए. ओके, अब डिपेंड करता है कि पेशेंट स्टेरॉइड सेंसिटिव है, स्टेरॉइड डिपेंडेंट है, स्टेरॉइड रेजिस्टेंट है, या फ्रीक्वेंट रिलैप्सर है या इनफ्रीक्वेंट रिलैप्सर है. लेट्स सी. यहाँ पे रेमिशन हम लोगों ने देख लिया. 3 consecutive नेगेटिव सैंपल्स. रिलैप्स मतलब दोबारा क्या हो जाए? लगातार 3 दिन प्रोटीन्यूरिया हो, एंड दैट टू इन रेंज ऑफ 3+ and 4+. अब अगर मैं फ्रीक्वेंट रिलैप्सिंग नेफ्रोटिक सिंड्रोम की बात करूं, फ्रीक्वेंट रिलैप्सर, तो फ्रीक्वेंट रिलैप्सर की भी कई डेफिनेशन है, बट रिमेंबर इन दिस वे, ग्रेटर देन 3 रिलैप्सेस और 3 or equal to within 6 months or 4 or more in 1 year. इससे ज़्यादा है तो दिस इज फ्रीक्वेंट रिलैप्सिंग नेफ्रोटिक सिंड्रोम। ओके, इससे कम है तो इनफ्रीक्वेंट। अब यहाँ पे बात आती है स्टेरॉयड डिपेंडेंट नेफ्रोटिक सिंड्रोम। स्टेरॉयड डिपेंडेंट कब कहोगी? जैसे ही स्टेरॉयड ट्रीटमेंट बंद करो, जैसे ही 6+6 वीक खत्म हो, उसके बाद क्या हो, विद इन 2 वीक्स में रिलैप्स हो जाए, या जब ऑल्टरनेट रेजिमेंट पे ले रहे हैं तब रिलैप्स हो जाए। तो स्टेरॉयड डिपेंडेंस मीन्स रिलैप्स on alternate day or within 2 weeks of stopping steroids. 2 weeks of stopping steroids. सिंपल है। स्टेरॉयड रेजिस्टेंट कब कहोगे? व्हेन इन स्पाइट ऑफ गिविंग स्टेरॉइड्स इन फुल डोज फॉर एटलीस्ट 8 weeks there is no remission in patient. So you have steroid resistant nephrotic syndrome, 8 weeks steroid and no remission. क्यों हम लोग इसको डिवाइड कर रहे हैं? बिकॉज यू हैव टू ट्रीट अकॉर्डिंगली द पेशेंट। ओके, लेट्स सी। हम लोग कहेंगे मान लो स्टेरॉयड डिपेंडेंट नेफ्रोटिक सिंड्रोम है या फ्रीक्वेंट रिलैप्सिंग नेफ्रोटिक सिंड्रोम है, यू हैव टू गिव स्टेरॉइड फॉर अ वेरी लॉन्ग पीरियड ऑफ टाइम, प्रेफरेंसली फॉर द पीरियड ऑफ 1 year। ओके, लेकिन अगर थ्रेशोल्ड आपका रेमिशन के लिए 0.7 मिलीग्राम पर केजी से ज़्यादा है, then you have to think of steroid sparing agents. Okay, and here steroid sparing agents में you have 3 options and drug of choice is mycophenolate mofetil और levamisole. अगर steroid sensitive है, give steroids for 6+6 weeks. मान लो कभी इसमें रिलैप्स हो गया, अगेन start steroids at the rate 2 milligram per kg until patient goes in remission and then give 4 weeks of alternate day therapy. Okay, लेकिन अगर frequent relapser है या स्टेरॉयड डिपेंडेंट है, इसका मतलब लंबे टाइम तक स्टेरॉयड देना है, गिव एट द रेट 0.2 to 0.3 मिलीग्राम पर केजी alternate day for 12 months. Okay, and then depending on the revision you can increase or decrease the dose. अगर 0.7 मिलीग्राम पर केजी से ज़्यादा की ज़रूरत हो, stop steroids and go for steroid sparing agents, right? Best one is mycophenolate mofetil followed by levamisole. Okay, what about treatment of steroid resistant nephrotic syndrome? Here you have calcineurin inhibitors in form of tacrolimus or cyclosporine. So this is all about treatment of nephrotic syndrome. You guys need to know extra. We did discuss that nephrotic syndrome has more chances of infection. Okay, be it due to loss of complement proteins, be it due to treatment with steroids. So you need few additional vaccines to prevent patient against capsulated bacteria in particular, क्योंकि ऐसे लोगों में एसाइटिक फ्लूइड के इन्फेक्टेड होने के चांसेस होते हैं बाई स्ट्रेप्टोकोकस निमोनी। न्यूमोकॉकल इन्फेक्शंस राइट आर वेरी वेरी कॉमन इन केस ऑफ स्पॉन्टेनियस बैक्टीरियल पेरिटोनाइटिस। तो उसके लिए न्यूमोकॉकल वैक्सीन दे सकते हो। यू कैन ऑल्सो एड अदर वैक्सीन्स, वायरल वैक्सीन दैट इज चिकन पॉक्स एंड इन्फ्लुएंजा एटलीस्ट 1 month आफ्टर स्टॉपिंग स्टेरॉइड्स। ओके, ताकि इम्यून रिस्पॉन्स इन वैक्सीन से और बेटर जनरेट हो। ओके, 1 month एटलीस्ट आफ्टर completion of therapy if you are talking about steroids. Now let's talk about few multiple choice questions. All of the following are decreased in nephrotic syndrome except. देखो कुछ चीज़ें टेक्स्ट पे नहीं होगा बट लेट्स अंडरस्टैंड। डिक्रीज्ड ट्रांसफेरिन, डिक्रीज सीरम फाइब्रिनोजन, डिक्रीज सेरुलोप्लाज्मिन, डिक्रीज सीरम एल्ब्यूमिन। सी विच इज़ नॉट डिक्रीज, दिस इज योर क्वेश्चन। हम लोगों ने कहा है दिस इज प्रोटीन लूजिंग नेफ्रोपैथी। प्रोटीन लूजिंग, तो प्रोटीन्स लॉस्ट हो सकते हैं इन फॉर्म ऑफ व्हाट? थायराइड बाइंडिंग प्रोटीन्स। ओके, हो सकता है हाइपोथायरॉयडिज्म के फीचर्स मिले, हो सकता है कैल्सीट्रायोल बाइंडिंग प्रोटीन्स बाहर निकल गए हों, कैल्सीट्रायोल बाइंडिंग प्रोटीन्स, तो कैल्शियम भी कम मिले। ओके, ट्रांसफेरिन दैट इज आयरन ट्रांसपोर्टर sometimes gets lost in urine, so you can also get features of iron deficiency anemia. But we did discuss that serum fibrinogen increases, okay, resulting into hypercoagulability. So multiple proteins can be lost, including complement proteins, but few proteins are synthesized in more amount. And one of them is fibrinogen, right? Therefore, you get hypercoagulability in case of nephrotic syndrome. Another which is seen in nephrotic syndrome. एक बार फिर से देख लेते हैं. एंटीथ्रोम्बिन 3 is lost in urine. तो ज़्यादा तो नहीं होगा, राइट? लो लिपिड तो होना नहीं है. क्यों? क्योंकि दिस इज व्हाट, हाइपरलिपिडेमिक स्टेट. हम लोगों ने डिस्कस किया है. प्लेटलेट एक्टिवेशन एंड यू हैव लो सीरम कैल्शियम. ओके, तो प्लेटलेट एक्टिवेशन भी नहीं होना है. यहाँ तो प्लेटलेट से रिलेटेड कोई बात ही नहीं हुई है. देयर इज नो एंडोथेलियल इंजरी, नथिंग. So this option is again wrong. There is loss of antithrombin 3. There is hyperlipidemia, and there is nothing related to platelet activation. Low serum calcium due to loss of what? Calcitriol binding protein. Okay, very very simple. चलो कुछ क्वेश्चंस और देख लेते हैं. The most common gene defect in idiopathic steroid resistant nephrotic syndrome. हम लोगों ने हेरिडिटरी कॉजेज में कहा था 2 जीन डिफेक्ट्स हो सकते हैं, एक NPHS1 एंड एक NPHS2. यहाँ पे हम लोगों ने डिस्कस किया था दिस जीन म्यूटेशन कैन रिजल्ट इनटू स्टेरॉइड रेजिस्टेंट नेफ्रोटिक सिंड्रोम. फिनिश टाइप में यू हैव NPHS1 एंड द प्रॉब्लम इज विथ नेफ्रिन. ओके, नेफ्रिन. सो आंसर फॉर हियर इज नेफ्रिन. I think this is enough for nephrotic syndrome. See you in next lecture of nephrotic syndrome. Bye bye. Take care.